Okay, so everyone, welcome back to the summer course session or the lecture sessions. Hopefully, you already got your lunch meal, and hopefully, you already have your stomach full for some of the meals. And this is the crisis time after the lunch, I think so. If you want to just grab or just wash your face with some water, it's okay. And after this, we will join for the third panel for the summer course that discuss about the aging. There will be 5 speakers from overseas speakers from Taiwan, Malaysia, Finland, and also another countries. And to commemorate this panel, I would like to invite one of our lecturers from Department of Health and Nutrition, Faculty of Medicine, Public Health and Nursing, Universiti Gajah Mada, Mr. Tony Arjuna, Ph.D. By the way, he is a dietitian in this faculty. For the next sessions, I will give the stage to Pak Tony.
Good afternoon, everyone. Some people look still a bit drowsy at this hour. All right. Okay, so we'll begin the third panel for the summer course 2023. And today, we'll have a very interesting topic on aging. So we'll be listening to lectures from different experts across different disciplines who will be sharing with all of you guys, both here and also the one joining online, about how precision medicine can transform service delivery in different areas of health and medicine. Okay, and for the first panel, I would like to invite Prof. Huang from Taipei Medical University, who will be sharing with us about cell-based therapy, mechanism, safety, and biodistribution. Can we give a big round of applause for Professor Huang from Taipei Medical University?
Is that okay?
Yes.
Yeah. Thank you so much for good introduction. I'm really honored and a pleasure to be here to share some of the precision medicine, and today talking about aging is stem cell therapy. So I'd like to cover about the safety, biodistribution, and disease treatment. First of all, I would like to introduce some of our friendship between the TMU and the UGM. That is the first time I visit UGM, 2015. So you see, we visit the Faculty of Medicine. So we have a lot of discussion and a lot of, I would like to show the acknowledgement. Yeah, so the funding agency from the Taiwan Ministry of Science Technology, and this work cooperation with the academician Saleem, the United States, USC, University of South California, NTU, and Academic Seneca. So that is my lab. So we have a lot of international students, came from Indonesia, Australian students, and the India, and the Vietnam, and Africa, and the American. So welcome to join us. So we have a global language, so everyone can enjoy not only for scientific discussion, but also different country culture. So for this work, I would like to thank you for these two doctor. Right now has been working in NTU hospital, and also here is Nova, the one came from the UGM. Thank you so much. So that is my talk. Thank you so much for your attention. I will happy to take a question after the talk. Thank you.
Thank you very much, Prof. Rita. Very interesting topic on an ever-growing field. We're probably unsure at this stage, very early, but then have a very huge potential. You're welcome to sit over here, Prof, and while we're waiting for the next panel. Thank you very much. And for the next speaker, it's another good friend of UGM. She's been coming here this year even twice, and would like to invite Dr. Ida. I always call her Dr. Ida because she's a good friend. So, but she's Dr. Noraida Omar from UPM, Malaysia, and she'll be talking to you guys about the role of nutrition in aging. So all of you, I'm sure lots of you have grandparents and parents and older people around you, and then Dr. Ida's information today will be very useful, not only for your practice in the future, but also for your own family as well. So let's give a big applause to Dr. Ida.
Okay, Assalamualaikum. A very good afternoon to everyone, ladies and gentlemen. Can you hear my voice? Hello, hello. Okay. Okay. Thank you for the kind introduction, Dr. Tony, my good friends. Okay. Okay. Today's topic given to me about nutrition in older people. Okay. So I'm Noraida from Universiti Putra, Malaysia. Okay, so this is the place that I come from Universiti Putra, Malaysia. This is my faculty. Okay, point is not working. Oh, point. And then this is my hospital, yeah, my hospital. Okay, hospital Sultan Abdul Aziz Shah. The place that I'm working, I have the clinic diet warga emas, geriatric diet clinic. Okay, so this is the outline for today. We are speaking on the older adults, what actually the nutritional issues, both of dietitians and also medical nutrition. Okay. So I'm a dietitian, I'm not the nutritionist. Okay, I hope you know the differences between nutritionist and also dietitian. Okay. Okay, so yeah, this is my family, my dad, my mom, and also my grandparents. Okay, so realize or not, in our daily life, we are actually living with older people. Okay, so nowadays, the life expectancy of older adults is increasing. So, and then we hope that by increasing age, they have a healthier life. Okay, so and also a higher quality of life, that we can reduce the burden of the hospital costs. Yeah. Okay. So referring to Malaysia, so I speaking in terms of Malaysian people. So 10% of our population actually older population. Yeah. So when talk about the older patients, so we need to understand their characteristic. Yeah. So they have a higher degree of frailty, have a multiple acute and chronic diseases, and age-related degenerative changes. Okay, and also, yeah, some of them have a decline in physical, cognitive, and also social function. Okay, so that increase the requirement for rehab. Okay, so that they need more supportive from their families, friends, okay, and psychological and also social care. So that requires the holistic approach and also how to reduce or increase living independently. Okay, so to understand the characteristic, we also need to understand their issues. Okay, so older population have the psychological issue and also psychological issue. Okay, for the physiological issue related to the decrease of the physical function, related to eating and also preparing food. When patients have a limited of the physical function, very hard for them to eat and also preparing food. Yeah. And also oral problems that impact of the respiratory function. They have a swallowing problem that leads to the food avoidance. Okay, some of the patient doesn't eat well because of their limitation. Yeah, and also decrease the enjoyment of food. Okay, due to the reduction of the taste, smell, and also sight, visual impairment. And also, yeah, many of them have multiple medication. The polypharmacy, I think this topic will become after this, okay, that making that affect their appetite, okay, leading to the anorexia of aging. Have you ever heard about the anorexia of aging? Yeah, so the loss of appetite actually the common issues among older population. Okay, apart from the physiological issue, they also have a psychological issue related to their cognitive function that related to the food. So this issue actually mainly the major contributor to the weight loss. Okay, so they have bereavement, depression. Some of them is having the isolation, reduced social function, okay, dementia, and also poverty. So less of the socio-economic constraint that reduce their appetite and reduce their ability and also motivation to purchase the food. Yeah, when we want to prepare the food, we need to purchase first. Yeah, so by having the limitation, limit the power to prepare the food and also consume the food. So yeah, living alone also need motivation to cook. Okay, so cooking for one maybe some give some issues to the older population. Okay, so older population always reflect their appetite decline. So you need to understand why older people having early satiety. Okay, early satiety may be due to delayed gastric emptying after consuming food. So the food remain in the stomach for the longer period compared to the younger population. This is one of the issue. And also reflect the satiety hormone. So the satiety hormone is increasing for the older population compared to the younger population. These two issues actually affect their appetite. So yeah. So physiological and psychological factor influence the nutrition intake and also status among older population. So changing the body composition have effect on patient nutritional status and also requirement. That's impact why older population having lesser energy requirement compared to the younger population. Yeah, and also decrease in both lean body mass, okay, and also total body weight. Increase the risk of the sarcopenia and all the chronic diseases, osteoporosis, and leading to the disability. Okay, and also when patient having frailty, that increase risk of falls and also having easy to have the infection, that risk the increased risk of the morbidity and also mortality. So changing in the body composition, this also we need to understand why older population having a different requirement compared to the younger population, because older population easily to gain weight. So gain weight reflect the gain of the fat mass, not the lean body mass. Increase the fat mass. Okay, so increasing the fat mass, especially on the abdominal fat and also the visceral fat. Okay, very harmful for the patient. So normal weight obesity is common. Have you heard about the normal weight obesity? Patient BMI normal, but when you do the BIA, we can see that higher fat mass compared to the lean body mass. Okay, so yeah, this one also patient not aware about the risk. Patient looks by appearance looks normal, but yeah, the risk of getting all the diseases still high. Okay, with the normal weight obesity. So the third point is the lean loss of the lean muscle mass, the fat-free mass. Okay, so by reducing the mass, so the muscle in our body actually give us the strength and also power. When we have the loss of the power, that lead to the no strength to do the physical activity. Okay, and patient slowing down, leading to the sedentary lifestyle. Yeah. So these 3 points, changes in the body composition, increased risk of the diseases, especially all the non-communicable disease, the cardiovascular disease, the osteoporosis, and also sarcopenia, and also decrease overall strength and also function. If you see patient, older population choose to be sitting. So that's why, because they are fragile and also fatigued. Okay, so focusing on Malaysia. So Malaysia, we have the dual burden of malnutrition. We have one population who are malnourished, and now another one is the obesity and also overweight. Yeah. So this is based on the NHMS 2018. Okay. So by having both double burden population, increased need of the holistic approach how to manage this population. Apart from the overweight and also malnourished, this is the common nutrition issue based on the NHMS data. So 90% of them doesn't consume adequate nutrition, focusing on the fruit and also vegetables. Okay, 30% of them having physical inactivity, lead the sedentary lifestyle. 10% having the food insecurity. 17% having depend on the others on the basic daily activities. 43% depends on others on the activity instrument daily activities. Okay. So when talk about malnutrition, this is the factor, the characteristic of malnutrition. The patient should have at least 2 of these 6 following criteria. So patient malnourished, we assume that they have insufficient energy and protein intake, leading to weight loss. Okay, when patient having weight loss, intentional weight loss, we believe that not only the fat mass yang lost, they also have a loss of the muscle mass, loss of the subcutaneous fat, and also the accumulation of the fat actually masks the weight loss. The patient losing weight, but we cannot see by our eyes the patient actually losing weight because they have the accumulation of weight that masks the weight loss. Okay, and also diminish the functional status as measured by hand grip strength. So in my clinic, I not only assess patient nutritional status, but I also assess patient functional status by using the hand grip strength. Okay, so focusing on patient in the hospital, is about 75% of the patient in the hospital actually malnourished. This data depending on Malaysian population. It's very highest, okay, compared to other care setting, but we can see that patient staying in the hospital having an acute disease that lead to other factors that affecting malnutrition. So why we need to have a greater attention for the malnutrition aspect? Because patients who are malnourished having 3 times of the higher of the hospital death, okay, and also 2 times longer of the hospitalization that impact to the hospital cost, and also 2 times higher discharge rate to the long-term care. They after discharge from the hospital, not directly to the home, they go to the long-term care for further arrangement, and then 2 times higher for the home health care services that needs to the support, and also increase the hospital cost by 73%. So okay, so Malaysian Dietitian Day from in our country, Malaysia, we celebrate for the theme of the malnutrition in older adults. We use the 3 S. The 1 S is the support, train, support, and also sustain. The 3 S actually impact the patient, the role of the dietitian in treating malnutrition among geriatric patients. Okay, so this is the role of dietitian. Okay, we use the nutrition care process. So I hope you're familiar with the word nutrition care process, NCP. In the NCP, we do the screening. Screening impact the first S to screen. And to support involving the nutrition assessment, nutrition diagnosis, and also nutrition intervention. And the last S is the sustain, referring the monitoring and also documentation. Okay, so screening of malnutrition. So have you heard about the nutritional screening? So who actually did the nutritional screening? It's not only dietitian work to perform. It's everyone involving in the healthcare setting can do the nutritional screening. Nutrition screening actually to identify the population who are at risk of getting malnutrition. Okay, but it's not the tool to diagnose the malnutrition. Okay? When we need to do the nutrition screening is within 24 hours of the hospital admission. So who will do the nutrition screening? Everyone available in the hospital, especially the administration staff, admission, the nursing, the medical staff, the diet assistant, and also dietitian can do the nutrition screening. Okay, how we assess this, how we screen the patient by using a very quick and simple, non-invasive, very minimal cost or not at all cost, non-technical part of the routine in the admission. Okay, so yeah, so how to do it? We have several tools that are available to use. Okay, have you heard about the mini nutritional assessment? M.N.A. M.N.A. is one of the tools to screen malnutrition, especially among geriatric patients. Yeah. So apart from the M.N.A., we have MAS tool, Malnutrition Universal Screening Tool. We have the Nutri-Score. We also have the Nutrition Risk Score. Okay, so depends on the location, okay, the hospital procedure, we can choose which one that available and appropriate to the department. Okay, but after do the screening, we identify those who are at risk of malnutrition, then come role of dietitian to diagnose of malnutrition. Yeah, so what is the nutrition assessment is actually to identify nutrition related problem and also to determine the severity and also causes. So when to do the nutrition assessment after you did the nutrition screening. Okay, who do the nutrition assessment is 100% by dietitian. So that's why patient we screen of the malnutrition, we identify those who are malnourished, we refer to dietitian. Yeah. So how to do it? We have validated tools to do a nutrition assessment. Must be comprehensive, a systematic approach to collect the data, to classify, and also to synthesize the relevant data to identify the problem. Okay, so one of the available tools is by E&D as per malnutrition diagnosis census statement. I will not go through every tool, but I just want you to know so that you can do your reading. Okay. Second one is the S.Gz subjective global assessment. Okay, you need to have the skill to conduct the S.Gz. Okay, other than that, the third one is a GLIM global leadership initiative on malnutrition. Okay. Okay, so there are 3 available tools to assess malnutrition. You decide which one is appropriate to your population. So, second of the support is medical nutrition therapy. Okay, medical nutrition therapy is our role as a dietitian to do the intervention to the patient based on the scientific evidence. Okay. So the goal of the geriatric nutrition actually to improve patient nutritional status as well as patient functional status, leading to the improvement of the quality of life. By having the higher quality of life, we actually can improve patient clinical outcome, yeah, and also reduction all the costs, because by having malnutrition, it gives the higher cost to the hospital and also to the patient, and also to reduce risk of the mortality. So this is the recently launched by our government, okay, Malaysian dietary guideline for older person. So I think it will available online on this December. So I would like to highlight there are 6 key messages, okay, on how to improve patient nutritionally. Later you can download. Okay, this is our Malaysian food pyramid. Yeah, so we focus on food pyramids to recommend the nutrition intake for the patient, and also we have the Malaysian healthy plate to educate patient on the portion size. Yeah. Okay, so by having food pyramid and also healthy plate method, so this is the how we do the meal plan. So for elderly population, for the man, usually about 2,000 kilocalorie per day. For women, about 1,780. Can refer to the second column. Yeah. Okay. So for patient, so that one MDG for healthier population. For patient, we have the Aspen guideline on nutrition and hydration in geriatric. They have a 2 version. One for the Aspen guideline, another one is the Aspen practical guideline. It's free to download, okay, but I would like to emphasize here, this recommendation having a general principle, malnutrition, guideline for the specific disease, and also guideline on the hydration. So, to treat older patient, to treat human, we obey with the ethical. Yeah. So the first oral option must be the first choice to treat the patient. If patient can consume orally, then we need to give normal food for the patient to consume. We also need to respect patient will and also preference. Okay, if patient not eating due to the wrong protein, for example, they dislike the chicken, then we need to replace with the protein that they like a fish and also all the plant-based. Yeah? So we need to ask patient. How we determine the requirement based on the ISPEN guideline. So normally for older population is about 30 kilocalorie per kilogram body weight, and actually it depends on gender, patient nutritional status, patient physical activity, any clinical condition that affect the requirement, and also lastly patient tolerance and also acceptance. Okay, it's no point to provide the higher calorie, higher protein if patient doesn't tolerate with the higher calorie and also protein. Yeah? So for the protein, at least 1 gram, 1 gram of protein per kilogram body weight. So for example, if patient weight 50, normal BMI, 50 times to 1 is about 50 gram of the protein to be taken on the daily basis. But again, to prescribe the protein and also energy, it depends on patient nutritional status, physical activity, other clinical problems, okay, or infection and wound will give a higher protein requirement, okay, and also patient tolerance and also acceptance. For patient malnourished or at risk of malnutrition, they need to have a more protein. Yeah? Okay, so I put fiber in my slide because fiber really important. So constipation is common among older adults. Okay, we aim for 25 gram of the fiber. Okay, how to convert to the serving? 25 gram of fiber equal to 5 servings of fruits and vegetables in our daily intake. Yeah? So fiber is really important to normalize the bowel movement. Yeah. If patient constipate, there are 3 factors to improve. 1 for educate fiber, 2nd educate fluid, 3rd one to encourage patient to mobile. Okay. Okay. So the last S adalah support. So the role of dietitian is to give the support, supportive intervention. We will go further later. Nutritional counseling. We give the food modification, the role of the oral nutrition supplementation, the role of the enteral feeding, and also parenteral feeding. So this is the supportive intervention. By doing the nutritional assessment in the sprint tadi, we actually identified the problem. Yeah? If patient problem not adequate intake due to not able to self-feeding, need help, then we need to provide the supportive intervention like a mealtime assistant. We need to ensure that there are caregiver or any assistant available during the mealtime. the assistant starting from the helping the patient to proper position during the feeding, or mungkin to cut the chicken to the small pieces. It depends on the need of the patient. Yeah. So yeah, home-like pleasant dining environment. So we need to improve the environment, exclusive the lighting, proper lighting. Okay, the good music. Yeah, if patient having the visual impairment, we encourage patient to wear the glasses. If patient doesn't apa tu, don't wear any dentures, okay, having the losing teeth, we encourage patient to wear dentures during the eating time. Okay, so this is the common thing. Patient having dentures, but during the eating time doesn't wear dentures due to rasa the painful or not properly fitted. Okay, that impact the eating satisfaction. Okay, and also we encourage patient to share mealtime with others. Okay, so that's very important to have the caregiver during the mealtime, not only to give the support, but also to make sure that they actually comfortable during the eating time and enhance the food intake. Apart from the supportive intervention, this is the role of the dietitian also to provide the counseling. Okay, so during the counseling for older adult, we not counsel the older adult alone. We invite the caregiver to be part of the session because the older adult doesn't have the power to make the changes, power to make the change. Okay. To give the awareness to the caregiver, so that the strategy that we provide to the patient can be implemented, can be sustained for the longer duration and then up to the second visit and so on. Okay, we have the individual counseling or group counseling, so it depends on the needs. Yeah? Okay, food modification. Patient having lesser requirement compared to younger population, but again the protein requirement still high. So comes the role of the nutrient dense food. Nutrient dense food. I hope you know what is nutrient dense food. By eating small and frequent meals, can achieve the energy requirement and also protein requirement. Yeah? So addition snack or finger food also maybe helpful in between meal. You give to the patient to increase the total energy and protein intake. And also if patient having swallowing difficulty, chewing difficulty, comes the role of the texture modified diet. Okay, that's suitable to the patient, that's safe to patient to chew and also to swallow. Yeah. Okay, oral nutrition supplementation. I hope you know about oral nutrition supplementation. It's all milk based. Okay, so the role of the ONS actually to compensate the nutrition intake by normal diet, referring to the total energy or total protein intake. So the aim actually to provide the ONS at least 400 kilocalorie, and also including 30 gram of the protein. Okay, but again we need to ask the patient about which flavor that they like. Okay, because ONS is really expensive, and when we start ONS, we need to give for 1 month, and then we assess the compliance. Okay. Yeah, compliance, ONS need to regularly assess because ONS is very costly. Yeah. Okay. Okay, and then when we start the ONS, we need to give for at least 1 month. So that's why when before prescribing ONS, we need to assess patient socio-economic. Okay, but we not supply the ONS. It's about the patient ability to buy and also sustain the ONS. Okay, if by prescribing ONS doesn't improve patient nutritional intake, comes the role of the enteral feeding. Yeah? Enteral feeding is indicated when oral intake is expected to impossible possible for more than 3 days, okay, below than half of the requirement, okay. So if we observe patient having deterioration of the food intake for more than 3 days, okay, then comes the role of the enteral feeding to take place, okay. But again, we need to assess the benefit and also risk to the patient, okay. Some of the patient afraid of the tube feeding, and also caregiver also doesn't pleased with the enteral feeding at home, then we need to have the other strategies. Yeah? To start with the enteral feeding, we need to discuss with the multidisciplinary team. Yeah? When we prescribe any intervention to patient, we need to discuss with the team. Come the role of the multidisciplinary team, and then always consider the nasogastric tube, okay, and also offer for the bolus feeding rather than continuous feeding, because we want to encourage patient to mobile. Yeah, I hope you can imagine bolus feeding, continuous feeding. Patient need to be bounce, okay, because they have a machine that will supply the milk continuously. For the bolus feeding, every 6 times during the meal time, so patient needs to provide the milk. Yeah. So yep. So tube feeding should be removed as soon as adequate oral can be re-established. So proper monitoring is really needed. Yeah. Comes the next S. Okay, so this is the multidisciplinary team, yeah, involving geriatrician. This is my team in the hospital UPM. So we have the AGILE. AGILE stands for Advanced Geriatric Integrated Care and Learning Center. We work closely in the multidisciplinary team. We have a geriatrician in the center, Dr. Hakima, me as a dietitian, other doctors working together to treat older patients, okay, including pharmacists, nurses, speech therapists, occupational therapists, and other healthcare professionals. Okay. Okay. The last S adalah sustain. So yeah, by providing all the intervention to patient, so the next step is to document. Proper documentation is needed so that other healthcare professionals that working with us can know and also update with the latest plan. Okay. Okay, this is the conclusion. Okay, nutrition screening of malnutrition should be done within 24 hours, okay, of admission. And then after we did the nutrition screening, then comes the nutrition intervention, diagnosis, and also monitoring. So early referral to dietitian after patient having classified as at risk or malnourished is needed, because early intervention can save lives and also can reduce the cost. Yeah. So dietitian actually the leader in the malnutrition identification. So always refer patient at risk of malnutrition or malnourished to the dietitian as soon as possible. And for the intervention, is reflect patient nutritional assessment. If patient need the support, then we give the support. If by supportive intervention doesn't help patient to improve, then comes the role of the enteral feeding and so on. Okay. So I think that's all for my lecture today. Thank you for your kind attention.
Thank you very much, Dr. Ida, for the interesting issues on nutrition for older people. And the next topic is actually related, very strongly related to this, which relate to aging and oral health in older people. It directly impacts how they eat, how they consume food. And we've got an overseas speaker from Finland today. We've got Dr. Abdel Hakim Saleem joining from University of Finland. Dr. Saleem, are you online yet? Can you hear my voice?
Hello, can you hear me?
Hi, yes, we can hear you, Dr. Saleem. Thank you very much. So we'll be giving you about the next 30 minutes to present your speech, and then we'll let you know when the time is close to 30 minutes. Thank you very much, Dr. Saleem. Time is yours.
Thank you very much. Is it possible to share my screen? So
yes, I think so. Yeah.
Yeah, so
Can you help please with the screen share? Is it enabled on the Zoom yet?
So I'm trying to. So if for some reason now, yeah, I think it's possible now to share. So can you see my presentation?
Yep.
Yes.
Okay, we can see the slide now. Yeah.
Yes. Okay, dear all, thank you very much for having me as invited speaker. It's my great pleasure to be in this summer course of Universiti S.Gz. Actually, I'm very happy and proud of have known and cooperated with esteemed scientists from the University of S.Gz, including my colleague and family friend, Dr. Tia Listiarifa. It's my pleasure really to be here with you today. And please let me know if you cannot hear of you or if the connection is weak, because actually, because sometimes I can hear some background, but I hope it's fine. First, I would like to introduce our research team. So my research team consists of Ph.D. and master students at the University of Helsinki, Faculty of Medicine, and we are located in Biomedicum Helsinki 1, which you can see here, and it is one of the largest research facility in Finland. And we are interested in studying different aspects of the head and neck squamous cell carcinoma with a focus on the role of phenotypic plasticity and oral bacteria in the development and progression of oral cancer. My team consists of a PhD student and dental student, Sine Karinen, and she's studying the role of lymphatic mimicry in oral cancer. And my PhD student, Rosa Huyanin, who is studying the role of vasculogenic mimicry in the development of head and neck squamous cell carcinoma. And dentist and PhD student, Mario Zanito, and she's studying the role of vesicles from the bacterial or oral bacteria in the development of oral cancer. And last but not least, Shrabon Hasnat, who is a dental student and doing his PhD on the role of intratumoral LBS in the development of oral cancer. And as you may know, that head and neck squamous cell carcinoma represents a group of cancers, common and deadly cancers that develop in the epithelial lining of the oral cavity, of the pharynx and the larynx. And according to the Globocan, in 2020, there were around 1 million new cases of head and neck squamous cell carcinoma, and about 500,000 deaths of this malignant disease. And thus it represents indeed a global challenge. As you may know, the very classical risk factors of head and neck squamous cell carcinoma are smoking and alcohol abuse, infection with the human papilloma virus, and the presence of what we call oral potentially malignant disorders, and of course the old age, which is quite relevant to the session today. As you may know, that old age is one of the most common risk factor for most of the cancers. And unfortunately, the mean age of the patients at the time of the diagnosis of head and neck squamous cell carcinoma is 65 years old. So, however, there is a surprising change in the trend, because now we have witnessed a lot of patients coming to the clinic with head and neck squamous cell carcinoma, and they are younger than 45 years old, and also it is more common in women now. It's very interesting, a change. However, we don't know the exact reason yet, but this is one of the interesting aspects in cancer research. Finland is not exception. For example, the incidence of head and neck squamous cell carcinoma in Finland has been increasing recently. And for example, in 2021, there were more than 800 new cases. And we are talking about a small country with very healthy lifestyle, but yet there is increase in the cases of the head and neck squamous cell carcinoma, including oral cancer, and the majority of the patients were old age over than 65 years old. So when we talk about head and neck squamous cell carcinoma, we also tend to talk about oral cancer or oral squamous cell carcinoma because it represents 1/3 of all the cases of head and neck cancers. And it's interesting that the most common site where we see this cancer is the tongue and the lateral border of the tongue. And why it's challenging, especially this oral squamous cell carcinoma? There is a famous saying, I don't know if you hear about it, they say that the family that eats together stays together. Unfortunately, cancer cells, they don't really follow this nice protocol because they start to eat together and grows larger and larger, and at some point they don't stay together at all, and they start to invade surrounding structures and disseminate local region. And oral squamous cell carcinoma in particular are characterized by very fast tumor growth and invasion, and then they metastasize loco-regionally because of the extensive lymphatic vasculatures in this area. And then when they start to metastasize, they move into the cervical lymph nodes. And once they are there, unfortunately, the survival rate is reduced by around 50%. And here we would like to talk about the metastasis because 10% of the patients with the oral squamous cell carcinoma, they come to the clinic with distant metastasis, and the cancer cells can metastasize preferentially to the, mainly to the lungs and to the bone. And however, 20 to 40% of the patients, they also present with cervical lymph node at the time of the diagnosis. So you can imagine how serious and how it's challenging this malignant disease. And now I would like to talk about metastasis because metastasis, as you may know, is the main cause of the cancer-related death in old age. And once we talk about metastasis, we will talk also about vascularization, including the lymphatics and the angiogenesis of the blood vessels, because it's a very crucial event and hallmark of cancer during a tumor development and metastasis. Unfortunately, the clinical trials that using anti-angiogenic or anti-angiogenic drugs, or what we call it angiogenic inhibitors, they failed to treat these patients, and actually the patients developed toxicity and very limited clinical outcome. We don't know the exact reason. However, there are some hypotheses that say that this could be attributed to the what we call it cancer cell plasticity. So cancer cell plasticity describes the ability of cancer cells to acquire phenotypic, like to acquire specific phenotype and functional plasticity, which allow them to have a stemness state. So here, for example, this figure shows the main features of this plasticity, or sometimes we call it cancer stem cells. They are able to self-renewal. They are able to transdifferentiate into different states or different cell types. And they are able to initiate cancer in vivo, and they are also able to differentiate and also invade the surrounding tissue and undergo metastasis. And finally, there is very also important feature of these cells that they are able also to resist the treatment, or what we call clinical tolerance or clinical resistance. So one of the important features is their ability to transition into functional endothelial cells. And this will eventually promote the tumor progression and metastasis, and also the drug resistance. So this takes us to talk about what we call vasculogenic mimicry. So this vasculogenic mimicry was first described by Professor Manitus' lab in 1999, and it describes the ability of melanoma cells. So they showed that some aggressive melanoma cells were able to transit into functional endothelial cell states in what we call it in very difficult or very harsh environment once they are under supply of or shortage of oxygen supply, and once they are there, actually they are able to resist the angiogenic inhibitors, which implies a very important role in the anti-angiogenesis, or what we call it anti-angiogenesis therapy paradigm. So there is one interesting study that followed that, which is published in 2011 by Soda et al., and showed that 20 to 90% of the endothelial cells in the mouse model of glioblastoma, which is very serious brain cancer and resistant to therapy, these endothelial cells were originated from cancer cells. So they didn't result from the fusion of endothelial cells and the tumor cells, but actually they were originally from the tumor cells that undergo differentiation into endothelial cells. Interestingly, these vasculogenic mimicry were responsive to the classical anti-angiogenic drugs, including Avastin. However, we are interested in the oral cancer, mainly in the lymphatic pathway, because lymphatics are the main route of metastasis in the oral cancer because of the presence of the cervical lymph nodes. So this was interesting finding once we discovered the main lymphatic markers, lymphatic vessel endothelial hyaluronic acid receptor 1, LUV1, and budoplanin. So these are the main lymphatic markers used in the cancer research, particularly in head and neck squamous cell carcinoma research. After the identification of these markers, we started to think, can cancer cells use or employ or exploit their phenotype plasticity in promoting lymphatic metastasis in head and neck squamous cell carcinoma? This led us to our hypothesis, and our hypothesis was that oral squamous cell carcinoma cells can employ phenotypic plasticity to transit into lymphatic endothelial states, which promotes cancer progression and metastasis. And this is mainly the work of our PhD students. So I would like to go briefly through our main findings within the last couple of years. So my PhD student, Sini Karinen, started to investigate the presence of what we call it lymphatic mimicry structures, meaning that lymphatic vessels originated from tumor cells in patients with oral squamous cell carcinoma. So we collected around 60 patient samples, and to be specific, it was 57 samples from patients with oral cancer. They were treated in Oulu University Hospital, which is a small city in Finland. And we started to employ the multiplexed immunofluorescence platform to use different markers and find any relevant structures. Compared to the normal vessels, so the normal vessels were positive for the lymphatic markers LUV1 and budoplanin. However, they were negative or almost negative for the CD44 marker, which is a phenotypic plasticity or stemness marker. And also, naturally, they were negative for the cytokeratin, which is oral squamous cell carcinoma marker or tumor marker. And once we checked for these lymphatic mimicry structures, it was very interesting to find some vessel-like structures that were positive for the CD44 and the tumor cell marker cytokeratin. However, they were negative for the budoplanin, but strongly positive for the LUV1. And it was more interesting that these structures were identified in 1/3 of these patients only. So it was not identified in all the patients, and this represented around 20 samples of the 57 patient samples. And thus we started to think, would there be any correlation with the survival and the clinical pathological parameters of these patients? And then we checked for this, and we found that the positivity or the presence of the lymphatic mimicry structure status, it predicted a shorter survival in these patients, meaning that the patients with the lymphatic mimicry structures had shorter overall survival after the diagnosis, and it was the mean was 58 months compared with 80 months in the lymphatic mimicry negative group. And more than this, the presence of these lymphatic mimicry structures were more in the older age group, meaning that the patients over than 45 years old. And next, we wanted to check whether cancer cells in vitro express lymphatic cell markers, and it was really interesting that the both metastatic and the primary cell lines, HS3 and SCC25, expressed the lymphatic marker LUV1, but not the pudiplanine. And for this, we used this highly sensitive droplet digital PCR, which gives absolute quantifications of the number of the copies of the lymphatic mimicry or lymphatic cell marker. And we used the human endothelial cells or lymphatic endothelial cells as a control. And this was also confirmed both at the messenger RNA level and also at the protein level. And then Sini checked whether these cells are able to form these lymphatic mimicry tubules in vitro and in vivo. And once we cultured the HS3 cells on matrigel, they started to form these tubules, and they were positive for the LUV1 and also for the actin. And they formed very nicely vessel-like structures. And very interestingly, we found that these structures were also found in the mouse samples. And for that, we used 8 mice, and we injected these mice with the HS3 cells in the lateral border of the tongues. And then after 7 days, these were collected and stained. And we found that the majority of these samples contained lymphatic mimicry or lymphatic, what we call a tumor cell-derived mimetic vessels. And these, all of these structures maintained a similar morphology with what we saw in the patient samples. And after that, this is the work of my student Rosa Huang. We started to ask whether there are any implications for personalized medicine approaches. And we showed that in vitro mimicry assays revealed variations among the tumor cells themselves, meaning that not all the cancer cells were able to form this tubulogenic network, or they had a different or variations in the tubulogenic potential. For example, here, these are the highly metastatic cells, HS3 cells, which formed a nice network of tubulogenesis, which is comparable to the human endothelial cells. However, the SCC25, which is a primary cell line, failed to form any consistent structures. Then we also checked whether there are any variations when we use different matrices, and yes, indeed. So what we used matrix from mice, which is matrigel, and also human matrix, which is myogel, and they showed different potential for inducing these tubulogenesis phenomena. And then we developed for the first time a novel model for studying mimetic vessels in vivo. And for that, we used the zebrafish larvae, and we used like 2 days old zebrafish. And we injected these fish with HS3 cells and also SCC25. And we used different matrices, matrigel and myogel, and we kept them for 3 days before performing imaging analysis. And it was very interesting that these in vivo studies confirmed the in vitro findings that HS3 cells formed these mimetic structures in vivo, while HCC25 and myogel failed to form such structures. And then we suggested this novel model as a possible platform and time-saving model to study the mimetic vessels in vivo. And then we started to think whether targeting LUB1 could affect the formation of these lymphatic mimicry vessels. And what we did is we silenced LUB1 in H3 cells and studied their ability to form these networks in vitro. And the knockdown of LUB1 showed nicely that these cells were not able to form any of those structures after the silencing compared to the silenced control and also to the wild type control. And then we also studied whether targeting LUB1 could also inhibit the cancer cell migration and invasion. And interestingly, and in line with our hypothesis, we found that LUB1 targeting impeded the migration of the HS3 cells using the oncocytes, and also they inhibited their invasion on the myoma disc model here, as you can see in the like silenced control compared to the silenced LUB1. And further, we started to ask whether targeting LUB1 can inhibit the metastasis in vivo. So the previous observations were carried out in vitro model, but then we decided to check this more closely in the zebrafish model. And what we did is we injected the H3 cells, both the silenced control and also the silenced LUB1 model, into these fish, and we incubated them for 3 days to check for the metastasis. And it was very interesting that the silenced LUB1 cells failed to form any metastatic colonies, while the control formed metastatic colonies in the tail and the head region. So then we started to frame our hypothesis, or to frame our findings into a general hypothesis that could be tested in other cancers as well, other solid tumors as well. So in the induced lymphagenesis, and this is what was believed before we described the lymphatic mimicry, in tumors, they induce the lymphatic endothelial cells to form small vessels into the tumor, and then they start metastasizing into the cervical lymph nodes. However, once the tumor, or in some aggressive tumor models, the cells don't wait for the lymphatic vessels to form these channels, but the cells themselves undergo phenotypic plasticity, and they start to express the LUB1 and starts forming these lymphatic mimicry channels to get access into the lymphatic vessels and metastasize to the cervical lymph nodes. And this is the first part of our studies. And then we started to think, okay, but the oral squamous cell carcinoma or oral cancers, besides their presence in very highly vascular region, they are also in direct contact with the oral microbiota. So we started to test the hypothesis that oral bacteria may contribute to the oral carcinogenesis by influencing phenotypic plasticity and other important precancerous processes in carcinogenesis. And for this, I would like to ask whether oral bacteria are just passive bystanders in this process. So again, oral cancers, as I said, they are in direct contact with the oral bacteria, and also it has been shown that oral dysbiosis can lead to chronic inflammation, for example, periodontitis. But more recently, they showed that 20%, 15 to 20% of all cancers are caused by infectious agents and chronic inflammation. And that's why actually the microbiota and phenotypic plasticity were added as a new possible hallmarks of the cancer in the last year. So I would like to pay your attention into a very interesting fact that oral bacteria produce extracellular vesicles. So these extracellular vesicles, they are very small particles, 40 to 200 nanometer in size, and they contain very strong virulence factors, for example, the cytolethal distending toxin, or what we call CDT, and also LBS. And actually, these bacterial EVs can affect cancer cells and influence carcinogenesis in different cancer models, for example, in GIT. So my students, Marius and Shrabon, we together we started to study whether these extracellular vesicles from oral bacteria can affect oral carcinogenesis and phenotypic plasticity. And for that, we started to isolate extracellular vesicles from different bacterial strains like Agrigobacter actinomycetomycetans and or what we call it AA, and we used different strains, wild type or CDT positive strain, and then to compare it with the CDT negative, we used the D7SS, which is very common, a mutant model of AA strain, but without CDT expression. And then we used also another AA strain, wild type, which express the LBSO, but another strain which missing or devoid of this LBSO, and to compare the effect of the two strains. And then we used also other common oral bacteria, for example, B. gingivalis and Ephenucleatum and B. micra. And it was very interesting. So I would like to go very briefly into these findings to save time. So what we found is that CDT expression in the extracellular vesicles was able to decrease these mimetic vessels formation in vitro. So this is the control. And when we used the CDT negative extracellular vesicles from AA strain, it showed increase in the thickness and also into the frequency of these networks in vitro on matrigel, and this was compared to a clearly decreased ability of the cells to form these networks when they were treated with these extracellular vesicles that are expressing the CDT. And just to let you know that what we did is we exposed the cells for 6 hours with these extracellular vesicles in concentration of 5 microgram per milliliter. So after that, we checked also the effect of these extracellular vesicles on the other pro-cancerous process, like, for example, cell proliferation, which is necessary for the growth and metastasis. So it was interesting that CDT expression inhibited only the metastatic Hs3 cell proliferation, here, the red one here. So compared to the control and to the negative CDT negative model, there was no really effect on the LBSO. And then we showed that Ephenucleatum, the extracellular vesicles from the Ephenucleatum, also reduced the proliferation of the both cancer cells, the primary cell model SCC24A and also the metastatic cell model HS3. And furthermore, we also showed that CDT expression in AA strain reduced the invasion of the highly metastatic Hs3, while B. gingivalis and B. micra increased the cell invasion. These are unpublished data, and we are actually now checking these hypotheses in vivo, and also we are studying the effect on the apoptosis, cell apoptosis and metastasis. So here the conclusions of our findings that in order to metastasize, certain aggressive tumor cells employ phenotypic plasticity to grow and invade the tissue barriers. And lymphatic mimicry we coined the term lymphatic mimicry in our group, which represents a possible new metastatic pathway in oral squamous cell carcinoma. And the CDT expressing bacteria mediate anti-carcinogenic effects in vitro, and this is now being checked in vivo. And also bacterial vesicles showed both favorable and unfavorable effects on the tumor cells based on the strain type. So the take-home message, oral bacteria are not just passive bystanders in the oral cavity, but also they are active contributors to oral tumorigenesis, and they possibly are able to influence phenotypic plasticity. Finally, I would like to thank you all. This is a picture of my students in our lab. Marriott was not there, she had a clinic, but we were doing some experiments. And here, actually, I would like to mention that my student, Rosa Huyanin, will defend her thesis, doctoral thesis, next month on the 8th of December in Helsinki, and it will be streamed online. However, unfortunately, the defense will be in Finnish, so it's probably not be very useful. However, this is the thesis book, and you can find it online. You can search vasculogenic mimicry in head and neck squamous cell carcinoma Rosa Huyanin, and it was based on 3 publications. So please feel free to download it and go through it. I would like also to thank the organizer for their invitation and Dr. Dia Bestia Rifa, and also I would like to thank our generous supporters and funders of these studies. And I am happy to take in any questions. So thank you.
Thank you very much, Dr. Saleem. So we'll keep the questions for later at the end of the session, Dr. Saleem, and I hope you can stay with us for a few more minutes until we finish the panel session. For the next one, I would like to invite the next speaker from another discipline. This time we'll be listening about the impact of polypharmacy in older people, and we've got a guest from University of Malaya. I would like to invite Dr. Izyan Binti Abdel Wahab to come to the stage. Let's give a big applause to her.
Testing. Yep. Okay, that's good. So this one is, I will close it. All right, Assalamualaikum and very good morning, everyone. Good morning, good afternoon, everyone. So I'm the 4th speaker for today. Thank you, Mr. Tony, for the wonderful introduction. I hope all of you can still survive for these continuous lectures. I know it's hard, but just bear with me for another maybe 20 to 30 minutes, I promise. All right. I'm Izyan Wahab. I'm from Faculty of Pharmacy, University of Malaya. By background, by profession, I'm a pharmacist, educator, and also researcher. So my area of interest would be medication safety in older people, in pediatrics, and also some special populations. So polypharmacy in older people, what is that? All right. Before I move deeper, I just want to make a disclaimer that all opinions, facts, and everything in my lecture is all by myself and not necessary from the university. All right. Okay, so at the end of this 20 to 30 minutes, I hope you get what is polypharmacy, what are the concerns about polypharmacy, and what can we do to strategize to make this polypharmacy seems less harmful. All right, no more lectures for me. It's just consider this case scenario. Mr. T is an elderly man, 84 years of age, who resides in long-term care facility, not at his own home, long-term care. He has been diagnosed with multiple comorbidities, heart failure, hypertension, arthritis, hyperlipidemia, and has a history of 2 MIs attacks, right? 8 and 2 years previously. He requires minimal assistance in his daily activities, which means semi-dependent. He might need to help by someone else to go to the toilet, perhaps, or wearing clothes, or else he can ambulate with cane, but maybe very, very slowly. His usual medications are, there you are, metoprolol, antihypertensive, aspirin, antiplatelet, all right? Omeprazole, okay, just a recap for everyone pharmacy students, medical dentistry, all right? Lisinopril, furosemide, potassium chloride, atobas for cholesterol, acetaminophen perhaps for his arthritis, tramadol as needed, again for arthritis, multivite, all right? How many? 10 medicines. Is that considered as polypharmacy? What do you think? We don't know. And then later on, he's transferred to ED, emergency department, for increased shortness of breath, okay, gasping for air suddenly. He's diagnosed with bronchitis at the ED and spent 24 hours at ED for observation. This is normal, all right? And then later on, transferred back to the long-term care facility for follow-up care, for the ongoing care. At that facility, the receiving physicians or practitioner reviews the medication list from the ED, from the hospital. Again, a list of 7 medicines: antibiotic, prednisone, tiotropium bromide for the bronchitis, okay, levopitrol, promethazine for the cough, haloperidol suddenly, and then bisacodyl. 7 new medicines in the list. And now he is prescribed with a total of 17. I'm not sure if you ever experienced this before, but maybe you can check back with your grandparents, with your parents, how many medications that they are now currently taking. Right, now, polypharmacy definition. By consensus, all right, around the world, it is actually 5. Per Mr. T, he has 17. 5 or more medications. Why 5? Why this cutoff? Why not 6? Why not 7? Why not 3? Why not 2? Because 5 has been investigated by many studies. It is associated with increased risk of adverse outcomes from the medicines. And these include fall, dizziness from many medicines, all right, frailty, inability to move around, disability, and also to some extent mortality. And then there's another school of thought. From this consensus of 5 or more, hey, there is also appropriate polypharmacy versus inappropriate polypharmacy. Because some medicines are really, really indicated for older person to treat multiple comorbidities. If Mr. T has 6 or 7, how come you can give prescribed that Mr. T with only less than 5 to avoid polypharmacy? That seems not logical. So that's why there's another term, appropriate polypharmacy. Let's have a look. Okay. So the concern of polypharmacy is that, yes, it is associated with hazards or adverse drug effects. For example, one drug named Twinstar. Twinstar is a combination of 2 antihypertensive, telmisartan and also amlodipine. Twinstar has at least 3 dosages. It's either 40 milligram, 5 milligram, 40 milligram, 10 milligram, and also 80 milligram, 10 milligram. If that Mr. T, has Twinstar perhaps at 40 to 5 milligram, combination of 40 milligram of telmisartan and 5 milligram of amlodipine, in some ways, if there is, a continuity of care and want to fill up another stock of Twinstar, maybe, there's some medication error can happen. 40 instead of 45, that Mr. T may also accidentally receive 40/10. And then when Mr. T actually take it, they can easily fall because of high dosage. Not only Twinstar, for many medicines. Fall is actually very prevalent around the world, and estimated of prevalence around 20 to 50% in older adult, and that might be underestimated. Second concern is that, yes, risk of hip fractures, so many medicines with this, all right, omeprazole, PPIs, and so on. And also prescribing cascade. Okay, this prescribing cascade, for example, if, okay, antihypertensive ACE inhibitor, perindopril or ramipril, can cause dry cough, and this may happen a lot more in elderly. But as a surrounding caregivers, family members, oh, this is not cough. This is not dry cough because of perindopril. It might be just a common cough. And then another prescription coming in for cough suppressant, just to treat for the adverse event, not realizing it may be because of the high dose of perindopril, maybe. So prescribing cascade can happen without us noticing it. Medication non-adherence, who can actually, adhere to 17 medicines in one day? We only have 24 hours, in fact. Right? So that's a problem with medication non-adherence as well, and prevalence of medication non-adherence in elderly is skyrocketing, up to 70%. They just get tired with taking many, many medicines early in the morning, which one in the afternoon, which one at night, and then goes on every single day. Transition of care, continuity of care is also very important, loss in translation, loss in documentation from hospital to long-term care facility to another clinic and so on. And that could actually contribute to the hoarding of the medicines and can go more than 20 medicines easily. Drug interactions, hey, yeah, okay. So this is actually, I don't want to say that it actually happens a lot, because if you open up reference book, BNF, British National Formulary, or any medicines formulary, they will always say, hey, these medicines will interact with this. It's like, every single thing will interact with each other. But which one is the most clinically significant drug interactions that can cause adverse outcome or can cause non-effectiveness of the medicine? So that could also be another concern that we don't know for sure, all right? All right, again, I want to bring Mr. T all the way for my lecture. Bear with me with Mr. T, okay? So strategies to prevent polypharmacy, of course, always encourage your elderly, your patients with elderly, your elderly patients to bring all their medicine. If you can, as a woman, have cosmetic bags, men have their own tools or accessory tools or bags, they must also need to have medication box or bag with them all the time whenever they go to see their doctors. That could actually trace all the medication, existing medication at that time, right? And then we as a pharmacist, we always do medication reconciliation when they bring the list of medicines in front of us for us to double check if this is actually indicated or not, right? And then link all medicines with the diagnosis. Discontinue unnecessary medications. Remember Mr. T, why he was prescribed suddenly with haloperidol? Do you know why it's haloperidol, in fact? It's an antipsychotic, all right? And then use a team approach. Consider goals of care of patients, and this is a must. The caregiver, we as a pharmacist, we need to identify who is actually the primary caregiver. The patients, the elder patients will not actually really know about their medicines. They might not actually really well versed with which medicines has to be taken in the morning or at night. Statin has to be taken at night. And then so the caregiver has to be there to know exactly, comprehensively, why this is so, why this is that, all right?
avoid high-risk medicines, use alternatives. We always can refer to, there's a tool, decision tool or assistive tool, what we call it clinical decision support system using stop-start criteria. You can Google up. There's also Beers criteria, drugs to avoid in the elderly where you can use alternative. They also recommend alternative, all right? And then remember, for all elderly patients, always start with low dose, avoid interclass duplication. For example, 2 antihypertensive in the same class, ACE inhibitor, why you are actually giving ramipril together with perindopril, sometimes accidentally, maybe because of there's a disconnecting of transition of care, all right? And also avoid medications to combat potential side effects, because the side effects actually might be because of the existing medications. All right, let's have a look at Mr. T again. Yeah, you can call me Mr. T, in fact, all right? Okay, so for the medication reconciliation, all right, let's have a look. There's always things that we can manipulate, not manipulate, amend the medicines for that Mr. T to have a very good daily lifestyle, all right? Metoprolol, is it for hypertension? There's no way that we can actually de-prescribe it, but we can actually reduce the dose. Aspirin, 325 milligram, that is seemingly high dose, which in fact, in many studies, 80 milligram has beneficial for as an antiplatelet. Omeprazole, why is that a high dose? Omeprazole also has been associated with hip fracture. There's always, you can always go it to lower dose. Why giving omeprazole? Perhaps because of the patients also taking aspirin, because aspirin can actually cause what? Gastritis. And also this omeprazole happens to avoid it. And then there's a list of medications that pharmacists and also medical doctors can always review together. So that's why a team approach must be there to avoid hazards from the polypharmacy, lisinopril, furosemide, and so on. Okay. So this is the medical list. After reconciliation, we can actually correct lower dose for metoprolol. What about aspirin? Reduce the dose. Lisinopril also can reduce the dose. Furosemide, potassium chloride, otherwise there's a list of medications that we can actually help to make it more appropriate so that appropriate polypharmacy is justified. Right? So in this Mr. T case shows an example of multiple comorbid conditions and polypharmacy, all right? We cannot avoid it. We cannot just make the rule of thumb. It has always to be less than 5, right? And then there are no obviously inappropriate drugs, and each medication has a clinical indication consistent with evidence-based. As for now, we are worried that why prescribe with haloperidol? There's seemingly no some sort of like psychotic behavior. This makes medication reduction and reconciliation difficult because of multiple comorbidities, different kinetics, pharmacodynamics, genetics, in fact, for slow metabolizers or in fact, high metabolizers. And when the medication regimens are adjusted, the patient should be monitored, re-evaluated regularly to check for any side effects. Right? For appropriate polypharmacy to happen, it has to be always monitored, re-evaluated again and again and again. So, in summary, I promise you it will be very short. Appropriateness of medication does impose superiority. This is my opinion. All right? Because many researchers around the world, they are still doing research when to, quantify the incidence or prevalence of polypharmacy using 5 medicines as a cutoff without considering the appropriateness of medication does impose superiority of the polypharmacy golden number of 5 or more, but always bear in mind on the risk of adverse outcome, all right? And I'm also aware that we are in the session of precision medicine. Can precision medicines help in polypharmacy? It's a huge challenge in this area because we always need to map out, need to consider about drugs kinetics, cellular kinetics, genetic testing, patients' multiple comorbidities, different environment, how you can actually, yes, there are few tools in precision medicines to help with polypharmacy, but it's not solid. It's not really taken into consideration of many factors, all right? And the research to produce one single precision medicine tool to predict polypharmacy hazards from it is actually very difficult, but the research is on the way, all right? For now, we as a pharmacist at hospital, we always refer to decision tool, okay, or maybe drug interaction tools, and also always to monitor, reevaluate, because one person to another will have different responses. Some elderly with even multiple comorbidities, even with low dose, they don't have any drug interactions, but perhaps other people can have drug interactions. So to have a single precision medicine tool to predict polypharmacy, the hazards of it, is actually maybe we need to slow down a bit, all right? But it is actually maybe for the future, for your generation to figure it out, all right? And most importantly, whether it can be accessible for everyone. Because remember, financial also comes into place, genetic testing, all right, especially. With that, thank you so much. That's all.
Thank you very much, Dr. Izyan. Very interesting way of delivering the lecture with the story of Mr. T. Thank you. And now we've come to the final session for today. And we're going to talk about a topic that I think many of you are passionate about. And we've got a very excellent guest from TMU as well, Prof. Hsiao-Chi Chuang. He'll be telling us about the impact of climate change, the issues that many of us care about, especially your younger generation, and then how does that impact lung health in older people. Time is yours, Prof.
Okay, so selamat siang. Okay, I'm quite proud to be here, and thanks for the invitation from the organizer. And today I would like to talk about how the environmental health, such as like public health, can be involved into precision medicine. So now some people call it environmental precision medicine. And for today's talk, I will talk about what is climate change, how would that be important, and how we can do the study in terms of like climate change, and how the clinical physicians or like clinical staff should respond to the climate change in the future. Okay, so it's surveyed in 2015 in American Thoracic Society. The question is asking about how many knowledgeable do you feel about the association between climate change and health impact? And most of the clinical staff, they replied moderate knowledgeable. So most of people think that will be very important, and they got a amount of knowledge in terms of like climate change. But how the climate change could be associated with work in clinical? And that'll be slightly less. It'll be like 41% of people in clinical, they think their job or like a clinical diagnosis could be associated with climate change in the future. But which way? This way. But the truth is, here is the temperature increase in Indonesia, and this is just an example. Actually, the temperature increase year by year. And this year, I do the visiting in London, and during, on July, that will be a very hot period, and the temperature should be reached to about 31, 32. But the truth is, I bring a lot of t-shirt with me from Taiwan to London. But the temperature would be around, there was around like 10 to 20, it's quite cold. So that's good excuse for me to buy more things in London. But the problem is there's still heat wave in Europe. So due this kind of like climate change, that could because a lot of things happen in the world, such as we call it extreme weather, that could leading to like floods, hurricanes, cold spells, or blizzard, ice storm, and so on. But, oops. Oh, press the wrong one. But based on the report on the UN, United Unit, they mentioned about that climate change is a very important issue nowadays. And there will be 88% of people being affected in the world. And there was 32% of the people, especially in Asia area, that could be affected by the climate change, especially for like extreme weather, and leading to 84% of deaths. And also from the Global Institute, APCC, they say like people with existing disease that could be more vulnerable in response to the climate change. And also they highlight that Asia would be the more vulnerable country or areas that could be affected by the climate change in the future. So what's the extreme weather and the respiratory disease? And lots of clinical respiratory disease has been considered as like an agent disease or like a lung agent. And most of clinical doctors, they think about asthma, COPD, or tuberculosis, this kind of like RTI respiratory infection disease are associated with seasonal. So most people think that would be the seasonal disease, for example, in like spring or in like autumn, there will be more cases being experienced acute exacerbation in clinical. But if we're looking at the data, we can find the asthma is kind of a seasonal response and seasonal variation, but the other disease, such as like a COPD, which is more or severely being affected by the season. So we go next. So we done a meta-analysis, and based on result, we try to looking at like any risk that will be happen on asthma outcomes in response to extreme weather. And for the result, we find like a emergency room visit, ER, and the mortalities of asthma could be much higher risk in terms of like climate change effect. And we go further to looking at the ER, the children, it's the vulnerable population, as well as the report I mentioned, the adult. So the fact in the UK, they also do research about like mortality from the heat wave in the UK, and here is the daily mortality in England during the summertime 2020. And for result, they can see the heat wave increase, also increase a lot of people deaths during the heat wave. And for the coast, there could be a lot of things that could happen. And for the future estimate, the heat-related death in the UK will be increased significantly on 2080. So that is a very severe problem we have to facing now. So what's climate change? And lots of people talking about climate change is weather or like a temperature increase. Actually, when the temperature increase, that also increase the level of air pollution. But in terms of like a previous study, most of the study has been done in toxicology, epidemiology. They mentioned about the air pollution is very important risk factors in terms of like cardiovascular disease. And from the WHO, they mentioned about the polluted air affect 92% of people worldwide. So which means like we cannot live without air pollution, especially during like under the climate change. That could be more severe pollutant levels in the future. So this is just a loop, and for the people, for human, our activities could increase the lot of pollutants in the air, in the atmosphere, and during that temperature increase, that could produce more, we call it SOA, secondary organic aerosol in the air, that could reflect the temperature or reflect the sunlight, and probably decrease the ground level temperature. But nowadays, based on WHO report, we try to reduce the aerosol in the air to improve the air quality. However, this kind of things could also increase the ground temperature as well. So this kind of like a circle. So we reduce the aerosol, probably increase the temperature. We try to reduce the carbon emission, and we also produce a lot of like emissions of pollutants in the air. So let's go back to talk about air pollution. So what the particle looks like. So normally we collect a particle on a filter subject, and we can use this filter subject to do the study, for example, doing like a toxicology study, or we do like a chemical analysis on the same time. But if we use like high resolution microscope, the particle will looks like that. You can see that it's very tiny. So each particle are present as nano-sized particle matter. So do you like doing like barbecuing? Yes? Yeah, there should be a lot of people like doing barbecuing. But can you imagine that when you do the barbecuing, you can see the smoke with black or with the brown, and this kind of particle or smoke could be dangerous to your health or to be dangerous to your lung, because these kind of particles place a platform and interact with lots of chemicals on its surface and increase its toxicity. And this is biogenic particles, which are from the flower pollen. And this kind of large particle can be inhaled and induce an allergy response in our upper airway. So as I just mentioned, due to like seasonal changes, and a lot of patients could be occurred by the pollen exposure and leading to like allergy response. And the next one is sulfate, which is produced by the photochemical reactions in the atmosphere. So this kind of gas can be reacted with like the other gas or free radicals and under the UV light, and to produce this kind of like crystal-like particles. So this kind of particles is really important in terms of like particle deposition in the lung. So in terms of like aerosol size or like lung depositions, normally we'll use these kinds of theories to talking about how we produce the drug for the inhaler. But on the other side, these kind of things could be also happen on the like toxicology in terms of air pollution. So when the particle being inhaled into a lung, it depends on our lung anatomy. So there are 3/4. For example, the large particle could be due to the impaction for the deposition in the lung. And for the smaller particle, that could be due to the flow rate reduction and leading to the particle gravitational settling in our like a middle airway. And for the tiny particle, that could be penetrated into like alveolar region. So that will be, I just mentioned, for large particles, when it's trachea being divided into two, that a lot of particles to being impacted here. But for the small particle, that could be due to the flow rate reduce and that increase the gravitational settling. So that could be deposited in our like small airway. But for the particles that less than 100 nanometer, that can be inhaled into our alveolar region. But these kind of particles cannot really be activate by itself. It has to cause by the bonding motion. So these kind of particles can partially interact with our alveolar region, such as the alveolar epithelial cell, but a large portion of these kind of particles can be also exhaled out to our lung as well. So here is is that working? So as we can see, here's a cartoon. So lots of bigger particles that can be trapped in our upper respiratory tract, and for small particles that can be like deposited in a lower respiratory tract. And for the tiny particles that could be deposited like in the alveolar region, leading to cancer risk increase. So different sizes of particles play different roles in terms of like a respiratory disease happened. But under the climate change, that could be changed or modified the aerosol physical chemistry and could increase its toxicity. Also could change the particle size, so leading to different particle depositions in the lung. So climate change is also an important risk factor in terms of modification of aerosols physical chemistries and could increase the risk for respiratory disease. So that's the paper we just published this year for the review how the climate change could associate like aerosols and how the physicians in chest doctor or pulmonologists in response to the aerosol or should response to climate change. So COPD is a phenotype for air pollution exposure or not. Lots of studies they mention about COPD or lung function decline could be caused by the air pollution. But the truth is 30% of the smoker could have the higher risk to develop COPD. But the COPD subject, 80% of the COPD subject or COPD patients have the smoking history. So that means if we are still keep in health, if you're a smoker, you still have a large portions could be not really having the COPD in the future. But there's still a lot of percentage of the other risk factors that could contribute to COPD development. So in terms of like COPD, there are two types. One is the bronchitis, and the other one is the emphysema. But in terms of like epidemiology study, we only focusing on lung function decline, and we pull the COPD subject together to do the statistical analysis. However, there are different phenotypes of COPD. Both of them are associated with COPD, associated with the air pollution or not. So that's the things we want to look at about, and the paper published in JAMA 2019. They do the two types of study design. First of all, is a question study. They find the air pollution such as ozone, PM2.5, or NOx, or black carbon, associated with emphysema in COPD. However, if we do like long-term follow-up, we only can observe ozone or NOx associated with emphysema progressions in the cohort study. But we go further. So in our lab, we collect clinical data and we collect HRCD data from the COPD patient. And we do further analysis. There are different phenotypes for emphysema by the lobar emphysema. So normally from previous study, they find like a smoker like could have higher risk in terms of like a central lobular happened. But from our study, we find like ozone exposure increase the risk for the penalobular. So that means the smoking or air pollution could have different phenotypes in terms of like emphysema. But if we go further, we find like a particle matter, PM2.5, which cause the higher risk in the lower lobe. And for the like ozone, and the NO2, that could have higher risk on the upper lobe. So different pollutants could have different effects on our lung lobes as well. So as a toxicologist, I am, and we try to build out the other approaches to study air pollution because we find the correlations in clinicals and we try to prove it in animals. So we establish normal approaches for long-term and concentrated air pollution exposure system for the animals, and we use this to the animal exposure for 6 months. And we use a genomic mice, which is a SPC quick ERT mice, which shows the red colors on 82 cells only. And we use this model to do the study. This will be the spectrum for our system, and also can measure the pollutant level over the 6 months. And after the 6 month exposure, we can see the lung function decline, especially by the PM2.5 exposure, and also the lung function decline associated with the metal level in the lung. So more pollutants we inhale into our lung that could be cause severe injury on our lung cells as well. And we do the HRCT in animals, and the red dot means like the emphysema. So after exposure, we can see a lot of emphysema happened in our mice model. So based on this kind of like imaging analysis, they give us more information about how these kind of things could be happening in animal after exposed to the air pollution. And we use different markers to prove it, our concept. And we use the SPC, which is a marker for the 82 cell, and the T1 alpha is a marker for the 81 cell. Both of them are decreased by air pollution exposure in animals. How about the human? So we collect the samples from the human as well. So this is a human healthy subject, and this is a COPD subject. And based on the images of the lung, and we can find the COPD subject have some particle deposit on the 82 cell, and we can see a lot of black dot on the 82 cell as well. And we do the IF imaging analysis. We also can see the SPC or T1 alpha decrease on COPD subject. So that raises a question, what's the potential mechanisms underneath in terms of like emphysema development in response to air pollution? So we use 82 cell and expose to the DEP, then do the RNA sequencing analysis. Of course, it proved that like SPC T1 alpha decrease. We also find the HIPPO pathway, which is a very important pathway in regulation of 82 differentiate to 81. And they also associate agent as well. And they also associate like lung development. So based on this kind of gene regulation, give us a knowledge or give us suggestions that further pathway can be examined, such as the HIPPO pathway I just mentioned. So we go further to examine the HIPPO signal pathway component, YAP, and test protein expression. And so we can see after exposure, we can see like a YAP test decrease, especially for the phosphorus. So which means the YAP of test being inactivate after air pollution exposure in the animal. So what happened? How can we do in response to the air pollution or climate change in clinical? So that raises questions in our mind. So we discussed with clinical doctor. So we decided to collect samples from biopsy in COPD subject, and we collected three subjects with different pollutant levels. So based on the biopsy samples, we do further proteomic analysis by the air pollution pollutant level, different pollutant level, and it shows that ITIH family proteins plays a very important role in response like emphysema and air pollution exposure as well. So we try to prove our concept by the clinical data and the serial work. Yeah, here is. So we collect blood to test the serum level of ITH4 in COPD subject, and you can see the severity increase of COPD, the ITH4 level decrease. So that means the ITF deficiency in COPD, and especially it to be associated with air pollution levels such as like PM2.5, and also the ITH4 deficiency associated with lung function decline as well. So we go back again to using the HRCT. We selected two subjects. One is a patient with a low ITH4 level in their serum, and one is high. And how is the emphysema severity by the HRCT? You can see the total LAA, the higher numbers of a total LAA, which means the higher emphysema by HRCT quantification. So based on the result, you can see that lower ITH4 patients in COPD had the higher levels of emphysema. However, for the higher ITH4 COPD subject have a lower emphysema. And we do the whole patient screening at the same time. Sorry. And we also can see the ITH4 present negative associations with the emphysema severity. So that means the ITH4 could be markers or could be sensitive in response to climate change and air pollution, which also can reflect emphysema as well. So I think it's almost a few slides now. So how we can facing to the air pollution under the climate change, that's some like strategy we can do, which has been reported in CHEST this year. And there's three triangle sites. First side is a provider, so that means like clinical doctors or clinical staff. So having a very good education to your patients will be very important. Ask them to avoid exposure to high levels of pollutant environment. And also ask them to wear the mask. And most of people, they spend a lot of time to earning the money or to caring their family, but you have to let them know. You have to know how to protect yourself in terms of like prevent the pollutant exposure under like heat stress. And the other side is for the patients, ask the patient to wear the mask and ask the patient to use the public transport. That will be very important rule because normally we use a private car. That will be very convenient, but it also produce a lot of pollutants in the atmosphere. And the other one is we need a lot of things to pursue the patients or a public to know what we're facing to, especially climate change. That will be a very urgent issue now. And last one will be the healthcare system. The government or the hospital need to play a very important role in response to the climate change, and they have to put more resources to to educate the public and move to zero carbon fuel option. We call it net zero. That will be the future. That will be very important for our future. And try to reduce a lot of things such as using a green car, the electronic car, and definitely you need to a very good power supply system as well for using this car. And finally, how the precision medicine can be used for in terms of climate change and air pollution. So lots of studies are doing now and to try to identify the suspected group. Especially we can using a genomic, proteomic, lots of omic study to see the vulnerable group that would be more sensitive to a heat stress, to higher level of pollution, and a lot of studies they show that, as I just mentioned, the children, the adults are more vulnerable in terms of pollution under climate change. And that'll be my last two slides. So I would like to say thank you to Dr. Farah. And I know her and Dr. Vincent since they were students in TMU before, and they're very happy to be here as they are now all doctors. And this is pictures, Vincent and me, we went to ATS this year in Washington, D.C., and there's pictures, he finished his final defense this year. And I would like to say thank you to everyone, and thanks for the organizer. And we have some students such as Amjad Maruna, and he's an Indonesian student, and Fatiem, and he's a pediatrician in UGM now. And all of them are studying our group. And thank you much. And terima kasih. Thank you.
Thank you very much, Professor. All right. Now we've got limited time for the last one because we go a bit over time. So we will limit questions to 3 students who would like to ask questions, either here or from the one available in Zoom. If you have any question, you're welcome to type it in, or you can ask directly. But I'll invite the one in here first, in the room here. Does anyone want to ask question to clarify information from all of our speakers today? One? Any other? 2? One more? 3? Right, okay. So, for those who want to ask question, you can go to the microphone on each side of the auditorium. So one over there and one over there. And we'll start one by one, and then we'll let the speakers answer the questions afterward. Okay.
Okay, thank you for the opportunity and for the amazing presentations. Here I have 2 questions. So the first question goes to Dr. Huang. Well, for me, stem cell is quite interesting. However, in Indonesia itself, there's a lot of controversy. So my question is there already a legal law or any regulation that could regulate about this type of medications? And how did the society in the Taiwan's react to this type of medications? And then my second question goes to Dr. Noraida. So you've mentioned earlier that for the elder people, they will need, does does their appetite actually related with their test? So I'm going to repeat my question. Does the appetite in older people related with their body compositions? For example, if the elderly is actively doing exercise and they can maintain their muscle mass, which means they will have more BMR, do they still lose appetite, or is it just happen in general? That's my question. Thank you.
Thank you very much. Okay, I think before you ask questions, so we don't forget, we'll let the speakers respond to the question, and I would like Prof. Rita to answer the first question. It's very interesting regarding rules and regulation, Prof.
Yeah, thank you. Very good question. I answer the second question first. So currently for the cell therapy regulation will be the country based. So that means different country, they will have a different regulation so far. Taiwan, we established the system by two track. The one will be we so-called medical technique, that means we so-called special management. So we have a positive list, for example, specific diseases, which has been approval by, finished the phase 1 clinical trial. And then we allow the clinical site to receive this patient for treatment. For example, for cancer therapy, for some of autologous immune cell for specific cancer therapy. And this cancer belong to stage 3 or 4 or no any other option can treatment. That is for cancer. And for other stem cell, for example, bone marrow stem cells for spinal cord injury or adipose MSC for some skin injury. So that is allowed. So, but you need to propose the proposal to the government, and then they will under the TFDA regulation and to review the proposal. The second part is according to FDA regulation. That means all the allogenetics or gene therapy or anyone, first in human, you need to apply the phase 1 clinical trial. So they need to fulfill all the FDA regulation, including the CMC and including all the proposal and the work condition, including criteria and the exclusion criteria, directly the same to FDA. So a little bit similar to Japan, but we a little bit conservative, only put the safety as the first, and then to go the efficacy. So that is the second question, and I forgot what is the first question?
The first one was about how does the people in Taiwan react to the regulation regarding stem cell therapy in general?
People in Taiwan reactive.
How does the public react to the regulation or the development in cell therapy in general?
Okay, so generally, Taiwan society, we really active and looking forward to the safety stem cell therapy. So currently, we already announced the draft for exosome therapy. So the exosome therapy, how we regulate the exosome quality and how to move on the clinical trial. We already have the draft, so now it's public for everyone's comment feedback. And the industry also feel very excited, because they move very straightforward to put the money into the cell product development. So for the patient, they request about the insurance. So the healthy insurance. So as I mentioned in another talk, so far Taiwan government already approved the CAR-T, the health insurance, and the gene therapy, the smooth muscle degeneration. So for the rare disease, for health care. So generally, Taiwan government and the people, really positive attitude for the cell therapy, not only for academic research, but also by clinical side and also in the industry.
Thank you very much, Prof. Dr. Aida?
Hello, Miss. Thank you for the question. Very good question. It's related to appetite and also BMR, right? Am I right? Yeah. Okay, from the lecture, for elderly patient, anorexia of aging is common. And so there are two factors. It's a delayed gastric emptying, meaning that the food remain in the longer period of time in our stomach, yeah, and also relate to the hormone secretion, satiety hormone secretion. But there are a lot of strategies to increase the appetite by doing physical activity. Yeah, so the more you do activity, it will increase the BMR, and then you can rasa lapar, you want to eat. Okay, by doing the activity, similar to how you trigger your sensory evaluation, you trigger the smell, and they also stimulate your appetite as well. Okay, so by sitting down, very sedentary, and then it will delay all the gastric emptying in our stomach. Yeah, so I hope I answered your question. Yeah, thank you.
Thank you very much, Dr. Aida. Second question.
Hello. Okay. I have two questions, but both is direct to. I would like to ask Dr. Izyan. My first question is like, what is the factors that lead to there is inappropriate polypharmacy, and is there any way forward we have done to decrease the prevalence of this inappropriate polypharmacy? And my second question is, doctor have emphasized on the drug and drug interaction. Then how about the drug nutrient interaction? Is it important also?
All right, thank you very much for your questions. Before you leave, I just want to clarify, rephrase back the question so that I do understand it better. So your first question was about the inappropriate polypharmacy. Why is it still happening? And then what could be the solution, intervention, or efforts being done so far? Second question is about...
is it the drug nutrient interaction?
Drug interaction, all
drug
right?
Nutrient.
Drug nutrient, you mean drug food interaction, is that right? Okay, thank you so much. Okay, so the first question is why inappropriate prescribing still happening? It's because, firstly, I think training must be there for all schools, for all health schools. That includes pharmacy, medical, dentistry, and this is actually needs some experience. It doesn't really, last, finish up until we graduate. That's why we will have postgraduate or in fact housemanship after that for continuous training, especially dealing with medicines. Secondly is that because of, I have to say this because it happens to my institution, maybe because of lack of workforce, all right? When there's a lack of workforce, too many patients coming in, and then there's a high potential for medication errors to come, to happen, all right? And we could observe that, when there's no clinical pharmacists in the wards, they could not do the medication reconciliation because of limited workforce. So the solution for that is that we are actually working on clinical decision support system, the digital way, how to incorporate that, embedded that in the electronic medical record so that even without clinical pharmacists around, they still need to be in, but still the dosing could be alerted directly when the doctors or others prescribe in the medical record. And then that could also alert them, signify them if this is actually appropriate or inappropriate. So we are actually working on that project. So that's actually our effort to combat inappropriate prescribing. All right, and this happens a lot when there's a limited workforce around. We need to, catering so many patients at one time. So timely decision is very, very important. Right. So your second question is about we are actually, why we are put so much emphasis on drug interaction. Why not drug food interaction? Okay, so. Thank you so much for that question. That's an excellent question. Back in our days, in my undergraduate training, maybe 20 years ago, all right, we always being emphasized on I'm not sure if there is any pharmacy students here. Citruses, foods, what do we call that? Citrus foods can also interact with many medicines, but it's not all citrus foods. Okay, some fruits doesn't have really significant drug-food interaction. They actually compete between apple and then oranges, and then I think grapefruit juice. So across all these citrus fruits, only grapefruits actually has some small significant interaction with drugs, but not for other citrus fruits. So to highlight about drug-food interactions, it has minimal interaction, I have to say that. That's why we are not emphasis on its importance or the danger of it. It's much more on the drug-drug interactions, but again, we only highlighted some clinically significant drug-drug interaction. And then, I know in NHS in the UK, they always pop up, system pop up, if there is any drug-drug interactions in the list, red alert, but then the pharmacist just stop it, because it's not really significant. It's just some significant, I can't remember now on top of my head now, but yes, we do have that list, that's important list, okay? I hope I answer your question. Thank you.
Thank you very much, Dr. Izyan. Last question.
Yes. All right. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. I bid to our panelists and participants here. So my name is Najmi from Universiti of Malaysia. So I have two questions. So my first question, I would like to ask to our first panel, Prof. Hua. I really interested in the cell labeling you were explaining before, which is the fluorescent diamonds. So my question is, if let's say the organ is injured, for example, kidney due to certain health conditions. So does nano diamonds may be affected on this condition for that kidney condition? And the second question, I would like to ask Dr. Noraida. Okay, so from what I understand, every disease might have its own meal plan treatment. Am I right? Okay. So in terms of geriatric, so of course, one person has the probability to have at least one or two comorbidities. So if let's say one person have chronic kidney disease stage 3, hypertension, and diabetes mellitus, so how does dietitian strategize to have a good meal plan treatment on this condition? And what would be the role of dietitian in making sure that this geriatric population really follow the advice by the dietitian, or is there any follow-up made on this situation? Thank you.
Thank you very much. Professor?
Yep, thank you very much for the good question. So your question is asking, when we use the narrow diamond for the biodistribution study, so in your clinical observation, so you think that will be harm for the healthy, right? So, okay, so the purpose for this study is to go for preclinical study to understand the stem cell biodistribution. So the main idea, individual body will be the animal. So we use it to do the mice over to the pig, but we don't use it in the human. Okay, so for human stem cell therapy, we will only pursue the clinical trial only after the preclinical study to demonstrating the MSC safety as well as the biodistribution to try to answer the pharmacokinetics and then move into clinical trial. So is that clear to answer your question? Yeah, good question. Thank you.
Noraida?
Hello. Okay, thank you for the question. That's a very good question that enlightened us about the topic today. The topic today, the lecture, based on the lecture, is not focusing on the multi-comorbidity. Yeah. So if patient comes to you, referred to you by the doctor, so that's time you need to prioritize. Okay. In clinic setting, hospital setting, we have acute disease and also chronic diseases. Okay. Based on our clinical judgment, we will prioritize. Okay. Based on the nutritional assessment, patient may have several issues. Okay. Then by look on the list, you need to prioritize. So we treat the acute issue first, and then to incorporate with the chronic issues. So CKD, hypertension, diabetes mellitus, which one is the top issue? Then we tackle the acute issue first. Yeah? So the second question about the how to ensure the patient follow our advice. Yeah? That's the role of dietitian, the third S, to do the support. Make sure that the support that we give to the patient can be sustained in their daily life. Okay. One of the options is by doing the monitoring and also follow up. In the clinical set, it's up to us to decide. Okay. Outpatient maybe depend on the critical issue of the patient. Yeah, maybe about 1 month or first in 3 months. Or 6 months after that, you follow up. Okay, but in the hospital setting, maybe we can do on the daily basis, see the patient. Okay, so yeah, elderly patient, not only to educate the patient, involve the caregiver in our plan, and also strategies to ensure all the strategy that we plan to the patient can be continue at home. Yeah, I hope I answer your question. Thank you.
Okay. Thank you very much, Noraida. I think now, because we've got very limited time, I will ask the final question actually, so we all get a take-home message that it's going to be actually useful for us, to Prof. Chuang. Considering that, I'm sure you've been traveling around Jogja as well, seeing the traffic and all the air pollution and the heat and everything. I've got 3 little kids who are, now that after COVID, we sort of forget about mask and everything. So what would be your advice for us to make sure that the vulnerable groups, as you said, will have a much better chance of reducing the risk of getting all the types of lung diseases in this condition, considering it hasn't been raining for how many months now? It's been late for 2 months, I think, in Jogja until last night. It was just a drizzle and not actually the rain that we expected, and still very hot, and with all the exposures or all the pollution around here. What could we do to make sure that everybody is healthy, especially the vulnerable one?
Okay, so thanks for the question, and it's very good. Because first time I arrived a couple of days ago, arrived Jakarta, and I can see it's very hazy. So for being air pollution, I know it's pollutant levels in Jakarta, but when I am in Yogyakarta, it seems like pollutant level seems like slightly lower. Yeah, but it depends on the season, because some countries that could be affected each other by the long-range transport air pollution. So how we can protect ourselves? Actually, it depends. If your home is semi-open, even you stay at home, it's still being affected by the outdoor air pollution. But for some countries, it's kind of like a fully closed, and due to like heat preserving, and try to like reduce any energy. And in this kind of room, I would suggest if the air pollution level is quite high outdoor, and would suggest the patients to go inside and for like long term, because I think these kind of things could protect and to provide more things in terms of like lung health. But if we definitely need to work outside and we cannot really avoid it, wearing a mask will be the cheapest, low-cost option to protect ourselves. Also, doing like an exercise, having a good nutrition, and to having a good drug compliance. I think everything should be very important because you have to keep in health. Then we can do further to think about how we protect our environment. Thank you.
Thank you very much, Prof. Chuang. Let's give a big round of applause for all of our speakers today. Thank you very much, everyone. Thank you for paying attention, staying awake throughout the session. I know some dozed off a little bit during the session, but well done. And we'll see you again in the next panel tomorrow. I'll hand over to the MC. Thank you very much. Thank you, Prof. Rita, Prof. Chuang, Dr. Izyan, and Dr. Aida. We'll see you again in the next session. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much for the speakers and moderator for panel 3. Give applause, guys, everyone. So can we take a photo together? And I'll just give you information. So stay tuned at the dialogue. There will be 1, 2, 3. 3 essay, short essay. Make sure as much as you can. So just your perception, just your opinion, but you have to use some reputable article, right? Make sure you read a lot of, not a lot, three scientific article to based on your perceptions, okay? So hopefully you can get it your assignment and you can submit your essay until November 20. Okay, so there is still a lot of time to do the essay. So thank you so much for joining with us. Our friends who are in the Zoom, thank you so much for coming and see you tomorrow at 8 a.m. Bye-bye, everyone. Thank you.